Good morning, everybody. Welcome to Grand Rounds. It's my pleasure to introduce our speaker this morning, Dr. Vinny Chulani. Dr. Chulani is the Section Chief of Adolescent Medicine at Phoenix Children's Hospital and the Medical Director of Phoenix Children's Gender Management Services. He did his pediatric residency in Brooklyn, New York at Maimonides Medical Center, and then did a fellowship in adolescent medicine at LA Children's. He's been at PCH since 2015. His clinical and research interests include adolescent sexual health and reproductive health in the care of LGBTQ youth. Dr. Chulani's contribution to promoting access to care and health equity for medically underserved adolescents has been recognized through numerous awards. He served on various local, regional, and national boards and committees and lectures nationally and internationally on a number of topics related to adolescent health. Please welcome Dr. Chulani.
All right, good morning, everyone. So I have to say it's a pleasure to be here in my home court, and hopefully I get some advantage, right? So it's really been a amazing journey, just advocating for LGBT young people. And this morning, I'd like to talk to you guys about intersecting identities and really bring forward the concept of intersectionality and how we promote health equity for racial and ethnic minority LGBT young people and communities in general. I have no relevant financial relationships to disclose. Other than that, I have a soft spot for young people. And I'm not sure that that shouldn't count as a financial relationship, because in our collective society, we have a lot to gain or lose according to whether our young people succeed or fail. In our collective society, we are all on the hook for how our young people turn out. As far as objectives to this talk, it's my hope that at the end of this session, you would each be able to discuss racial and ethnic identity development as an individual, concurrent, and intersectional process. Second, be able to define racial and ethnic and sexual stigma and chronic minority stress. Third, be able to describe disparities affecting racial, ethnic, minority, LGBT populations. And lastly, be able to describe an affirmative, trauma-informed, strength-based clinical approach to caring for and promoting health equity for LGBT communities and young people. So the term LGBTQ, which I may use interchangeably with this talk, describes the combined populations of lesbian, gay, bisexual, transgender, and questioning individuals who share historically marginalized status relative to cultural norms of exclusive heterosexuality and conformity to traditional gender roles and expectations. They are diverse. They come from all walks of life. They come from all backgrounds. And contrary to Muhammad Ahmadinejad's assertions, they are part of every community. Accurate data on the prevalence of LGBTQ identification is elusive because we don't ask questions about LGBTQ identification in large probability samples. We don't ask it in our census. And that alone is problematic because in healthcare policy and planning, you don't count until you're counted. Based on the Williams Institute data, however, so the Williams Institute is a massive think tank that's based out of UCLA that's really the purveyor and broker of LGBTQ-specific information on LGBTQ-specific issues. Based on 2016 Gallup poll data, they found that 4.1% of US adults identified as LGBTQ. That's a little more than 10 million. That number is 1.75 million more than the prevalence that was reported at the last Gallup poll from 2012. Now, there are also visible changes that are taking place in the demographic composition of the visible LGBTQ community, especially among young people and among racial and ethnic minorities. Based on that Gallup poll data, most of the observed increase in LGBTQ identification were among millennials, defined as those born between 1980 to 1998. In fact, with this shift, millennials were more than twice as likely to identify as LGBTQ than members of any other age cohort. There's also changes taking place in the demographic composition in terms of growth among racial and ethnic minority communities. Based on that Gallup poll data, this, by the way, is data from the CDC's Youth Risk Behavior Survey, where it found that only about 89% of in-school youth identified as being heterosexual, the rest as something other than. Based on that earlier Gallup poll data, What they found was that the largest increases in LGBTQ identification was also seen among racial and ethnic minority groups, specifically among African American, especially among Asians and Hispanics. And with this shift, we find that these communities now account for about 40% of the LGBTQ community. Now, we recognize that identity development is a fundamental task of adolescence. And the process and outcomes of identity development, the process and outcomes of the developmental tasks of these years must be viewed in the context of the surrounding structures, environments, and supports that envelop young people during these developmental periods. And it is in this context that I would like to talk about binarism. Western philosophy, our patterns of thought, reflect dualism. They reflect binarism, good and bad, fat and thin, short and tall. And binarism is not neutral. Binarism is not neutral. In binarism, there is a favored pole, there is a favored dominant pole, and a disfavored non-dominant pole. And power flows accordingly. Think about that. Power flows accordingly. When something or someone is defined as other than a subject, they become an object, and violence is justified. What is being oppressed is not a thinking, feeling human being with feelings, families, hopes, and dreams, but is an object that is devoid, that is other than the subject, that is devoid of families, feelings, hopes, dreams, aspirations. Let's talk a little bit about stigma. Stigma refers to the inferior status, negative regard, and relative powerlessness that society collectively assigns to members of non-dominant groups who bear with them non-dominant statuses, attributes, or conditions. Goffman described stigma as an undesired differentness. Now, sexual stigma is stigma that is attached to any non-cisgender or heterosexual identity, behavior, relationship, and community. Stigma can also apply to other dimensions of disadvantage. Any non-dominant status has stigma that can be associated with it, and that includes race and ethnicity. Now, stigma can be viewed from three dimensions: internalized, personally mediated, and institutionalized. And these dimensions reflect how stigma can affect one's self-concept, one's environment, and one's experiences. Internalized stigma is the acceptance by marginalized members of negative messages about their own abilities and their own intrinsic worth. So you know I provide services for homeless and runaway young people, and we provide gender services there. So I was working with this new patient one day, and she was 23, and she had graduated high school, but was sort of stuck in this limbo. She was working at a juice bar. Not to say that's not a noble profession, but we had a chat about, what do you want to be when you grow up? She goes, I want to be a school teacher. I go, well, how optimistic are you that you might achieve your dream? She goes, not really. Because which parent would really trust their child with a transgender teacher? Internalized stigma. Let's talk about personally mediated and enacted stigma. Personally mediated and enacted stigma results when cognitive bias, when prejudice or emotional bias, and stereotypes, which are differential assumptions of others on the basis of their membership in stigmatized groups, or cognitive bias, results in discrimination or behavioral bias. Over time, while we have seen a decrease in instances of macroaggressions, of overtly discriminatory acts, recognize that there's still microaggressions, right? The subtle influences. I hear it a lot. Well, she's so pretty. I didn't really think she was transgender. I didn't know she was transgender. What are you implying, right? What are you implying? LGBT populations make up 4% of the population, but 17% of all hate crimes reported in 2017 were against LGBTQ people. Institutionalized stigma. Institutionalized stigma refers to differential access to goods, services, and opportunities in society according to one's membership in a stigmatized group. It is normative, it is embedded in our institutions, and it becomes part of customary practice. When you take a look at health disparities affecting LGBTQ populations, these are not random generic health differences. These are differences that are systematic, These are differences that are the result of the historic and present unequal distribution of social, economic, and environmental resources. Now, stigma does not only affect self-concept, stigma affects lifelong health. The chronic minority stress theory describes elevated levels of stress that are faced by stigmatized minority groups, to which it attributes higher rates of anxiety, depression, and substance abuse affected by these minority groups. Chronic minority stress describes distal stress processes. Distal stress processes are processes that do not depend on an individual's perspective, such as experiences of discrimination, rejection, and victimization. Chronic stress can also come from proximal stress processes, which depend on an individual's perspective. This includes internalized homophobia, which we had previously defined, when an individual takes in and integrates negative messages about themselves and that are reflected from society that results in negative self-concept. Perceived or felt stigma, the anticipation, the expectation that one is going to be rejected and discriminated against, which leads to a state of vigilance and concealment of one's identity. And we recognize that these can contribute to adverse physical and mental health outcomes. When you take a look at the social determinants that affect LGBTQ health and that underlie disparities, these are determinants that are rooted in institutional stigma. These are a function of systems and structures. Let's talk a little bit about identity development, because we talked about how, we recognize that identity development, again, is a key task of adolescence. Let's begin with sexual identity development. So theoretical models for sexual identity development have been primarily described as a process of progression through stages and phases. Common to predominant theories, but whether they be fluid or staged, is that young people begin it really begins with an experience of confusion that and by the way, these models have been largely described mostly for lesbian, gay, and bisexual individuals. The models for identity development and conceptual development for transgender young people are still sort of being developed, but we recognize that there are certain common themes. Models contend that young people begin to experience confusion as they recognize that their patterns of attraction are different from those that are experienced by heterosexual peers or cisgender peers. With this awareness, they become mindful of heterosexism in communities, in society, which results in retreat and an immersion within the LGBTQ community. As they immerse themselves in LGBTQ communities, they establish contacts with openly identified LGBTQ individuals, including in dating and intimate relationships. And in a final stage of their identity development, they hopefully are able to integrate they're able to integrate their sexual identities, their gender and sexual identities within and into their overall adult identity. Now, personal acceptance and public acknowledgement of being LGBT or coming out is seen as an act and as a marker of developmental maturity, as a milestone. Now, contemporary models contend that maybe sexual identity development isn't quite so staged, that maybe it's much more fluid. Not only were the stage theories and the stage models based on the experiences of largely gay white males, but times have changed. But regardless of whether you look at stage or fluid models, the personal acknowledgement and public acknowledgement and coming out to oneself and to others is reflective of developmental maturity and is a developmental milestone for young people. This doesn't happen in a vacuum. This happens in the context of cultural supports. This happens in the context of exposures to affirming social institutions. One of the tasks that LGBT young people have to do in terms of identity development and coming out is to deconstruct their previously internalized expectations for the cisgender or heterosexual life course, and to be able to construct and view an alternative life course that is equally suitable. And I don't speak of this in a vacuum. I speak of this from personal experience. I have had to make my own journey from a place of self-loathing, born in the Philippines, to an Indian family where males are prized, more so male physicians, and in a culture where we are practically for sale to the highest bidder. And I have had to make my journey from that place of loathing to that place of pride. And I would not have been able to do it. I would not have been able to reach there without being able to view this as an equally viable lifestyle. This has to be viewed in the context of supports and affirming social institutions. Now, the concept of intersectionality highlights that we are multidimensional beings. We are not unidimensional. And the experience of LGBT people is heavily shaped by their experiences and by other conditions and attributes, especially race and ethnicity. Let's talk a little bit about ethnic identity development. So ethnic identity really talks about one's identification with and feelings of psychological attachment to an ethnic group. Now, theoretical models for ethnic identity development are also described in both stage and fluid theories. And models contend that young people begin in a state of relative unawareness about what it means to be a member of a specific racial and ethnic group, and that they may hold unexamined positive or negative views about this membership up until a critical encounter. This critical encounter compels them to examine the role of their race and ethnicity in life and in society. That critical encounter has been historically described as a traumatic, oppressive, or prejudiced event. We also recognize that many small negative incidents can prompt that immersion in learning and awareness of one's race and ethnic identity. The beautiful thing is that when you take a look at qualitative studies on racial and ethnic identity development, is you recognize that positive experiences can do the same. It allows us, it creates a window for us when we work with young people and families to foster racial and ethnic pride, to foster cultural pride as a way to build resilience. Because young people talk about hearing positive things about their history, their heritage, their families, as also promoting a sense of ethnic awareness. So following this critical encounter, they immerse themselves in their racial ethnic communities to learn more about this. Hopefully, in an integration phase that is viewed as occurring later in adolescence, they are able to come to a point of racial ethnic pride while at the same time valuing members of other racial ethnic groups and integrating their racial ethnic identities into their overall adult identities. Now, other dimensions beyond race and ethnicity also matter. You know, indigenous heritage, national origin, age, geography. You know, when I think of my young people that come to me from 6 hours away, I have a young person who's thinking about how might I transition in Pine Top? What does it mean to be an LGBT person in a community where there aren't really a lot of role models, where there aren't necessarily sources of support? Recognize intersectionality. We are not unidimensional individuals. And based on these, they confer dimensions of privilege and disadvantage. In my own personal story, I recognize the privilege of education. I recognize the privilege of social status that I have enjoyed, which is why I am here standing in front of you today. Let's talk about the impact of racism, heterosexism, and homophobia. You know, LGBT people of color experience disparities across many different dimensions. Not only are LGBT people of color known and well documented to experience higher rates of anxiety, depression, and substance abuse, which we know sort of goes back to chronic minority stress. We also recognize that LGBT people of color have lower levels of educational attainment, lower levels of high school graduation, lower levels of college education. They are among the most economically insecure in society. They earn lower wages. And when you take a look at households headed by LGBT people of color are more likely to live in poverty than any other demographic. They are vulnerable to discrimination in the workplace because of their sexual orientation, their gender identity, and their gender expression. And in many states in this union, you can still be fired for no other reason than. This results in economic insecurity. This results in sporadic healthcare coverage. This results in insecurities that really translate to outcomes. Economic insecurity and heterosexism in these communities are really reflected in high rates of homelessness among our LGBT youth. And I feel that I really need to speak to this, especially in the context of our homeless youth outreach program that works with LGBT young people experiencing homelessness. LGBT young people, as far as homeless youth, about 40% of homeless youth identify as LGBT. LGBTQ young people are 120% more likely to report experiencing homelessness compared to their non-LGBTQ peers. Once homeless, carving a path out of homelessness for LGBTQ youth is also difficult. Why? Because of their negative experiences in school, they're more likely to drop out. They're less likely to have the educational backgrounds that make carving a path out of homelessness more difficult. When you take a look at the literature, the causes of homelessness for LGBT young people are largely based on rejection by their families. A good number of them would have been forced out and kicked out by their families when coming out. When you take a look at the demographic composition of homeless LGBTQ youth, we know that Native Americans and African Americans are overrepresented. They come from low-income communities and working-class communities that have little access to economic resources once they find themselves homeless. There is no daddy Warbucks. In fact, for homeless LGBT youth that are much more likely to be commercially, sexually exploited, there's only daddy. So this reality is in stark contrast to media depictions of LGBT people. When you take a look at the media, the LGBT community is largely depicted from the perspective of white cosmopolitan males who brunch and powerful lesbian women who live in gentrified urban neighborhoods, who have double income, no kids, who have significant economic power and disposable income. And that's really not the reality for LGBT people, especially LGBT people of color. Let's talk a little bit about the clinical approach. How do we put all this together? The approach that I truly propose is an approach that is affirmative, that is trauma-informed, that is culturally humble, and that is strength-based. And for those of you that are interested, there's this publication that came out late last year, Promoting Health Equity Among Racially and Ethnically Diverse Adolescents, and I was fortunate to serve as editor on this publication. And I talk about this approach in that particular publication. Let's talk about affirmative. What is an affirmative approach? An affirmative approach is one that affirms that being LGBTQ is an equally positive human experience to a cisgender and heterosexual identity. It is one that allows us to work with youth to help them to arrive at a positive sense of self. It is one that really affirms who they are as individuals. But it is also one that compels us to reflect on our own biases, because you know what? We are not separate from society. We are cut from the same fabric. And we reflect their own biases. We bring those biases in clinical encounters. So I want to tell you a story of this 10-year-old birth-assigned female who I met in consultation last week. And the family came in and they're like, you know, my child, who was going by she, her pronouns, I shouldn't stay still, that's bias, you know, has been dressing as a male since she was 2 or 3 and has just, you know, but hasn't really asserted pronouns, hasn't reported distress in terms of primary sexual characteristics, hasn't expressed distress about the potential development of secondary sexual characteristics, and didn't really give you that typical story of dysphoria. But then again, you have to recognize that dysphoria, to a large extent, is a product of the environment. When the environment is affirming and supportive, dysphoria may not necessarily be there. Of course, there's still one's relationship with body, right? And I had to sit there and talk to these parents and reflect on my own biases and speak to my own bias, because I know where my bias lies. This is what I do every day. I'm way over here. And I went to this parent, you know what? I have to reflect on my own bias and speak to it. I'm not here to make your child trans. You might have a cisgender female child who just happens to like male clothing. You may have a cisgender female child who might one day tell you that she has a different pattern of attractions. Or you might have a transgender child. Whether your biases are one way or another, our task as clinicians is to reflect on our own biases, implicit or explicit. Let's talk a little bit about trauma-informed care. And I'll tell you that it's amazing the amount of work that's going into trauma-informed care. We have Himali Bhatt that's been involved in it. We have Marcia Stanton here at Phoenix Children's Hospital. So trauma-informed care is really a method, a process, a philosophy that recognizes that human service systems, service delivery systems, if not closely examined and modified, have the potential to exacerbate traumatic experiences of individuals who have experienced trauma. Being trauma-informed requires us to examine our service delivery system and be mindful of trauma triggers for people that have been exposed with trauma. Dr. Yablonsky is here. She's been a leader in the institution in this area. And what we need to do really is take a look at our service delivery systems. Think about the potential for re-traumatization, but beyond that, think about how we might create supportive spaces and affirming spaces that not only prevent re-traumatization, but promote healing. What are the principles of trauma-informed care, and how do we apply these principles to the care of trauma-informed youth? First, safety, trustworthiness, and transparency. We need to display images of diverse LGBT youth in our common spaces. We need to be able to communicate that these are safe spaces. We need to end any and all assumptions of cisgender and heterosexual identities by routinely asking questions about gender identity and sexual orientation in our intake processes. Peer support and mutual self-help. We need to reflect a commitment to LGBT inclusion in our recruitment and hiring. Our staff needs to reflect the diversity of the populations we serve. We need to create a space for our out and proud team members to be positive role models for the LGBTQ youth that we work with. We need to be able to partner with the patients and families that we serve and allow them to inform our programs and processes and services. And just last quarter, we actually launched Gender Proud, our family advisory council for our gender support service, and we're fortunate to have folks like Daisy Kunkel, who is over guest relations, really in there and taking a look at how we might sort of promote inclusivity. One of our projects is taking a look at how we suppress gender markers for our transgender patients or our patients who are registered as transgender, only because we have young people that have meltdowns in our waiting rooms because that gender marker is distressing to them. And that's part of creating safety. That gender marker is not a patient safety marker. If it is, we are doing something wrong. And that's something that we're really trying to tackle as a project of the Advisory Council. But part of being trauma-informed, part of trauma-informed care is recognizing historical trauma. That massive trauma that we as communities of color and LGBT individuals have encountered and experienced over the lifespan and across generations. From slavery to the Jim Crow laws, to Indian boarding schools, to the internment of Japanese Americans, to Charlottesville, to today's child separation and caging. From the historic harassment of gay people leading to the Stonewall riots, to the assassination of Harvey Milk, to the murder of Matthew Shepard, to the silence of the Reagan administration as HIV/AIDS ravaged our communities, which we still deal with, to the Orlando Pulse nightclub massacre. Being trauma-informed begins with recognizing the history of oppression and discrimination that we as communities have faced. Cultural humility. You know, we talked a lot about cultural competence, right? We viewed it as a fixed set, as a finite set of knowledge, of skills, of competencies that help us reflect the other. What did we do? We reduced populations into narratives of, Filipinos like pancit, right? It goes more than that. Now we think about cultural humility because we recognize intersectionality. Everyone brings something different to the clinical encounter. And being culturally humble means recognizing that we are never done learning, that everyone brings something to the table, and the task is to be flexible, to be humble, and to learn from the other and the lived experiences that they bring with us. But there are two factors that are central to cultural humility that I want to point out. First is a desire to fix power imbalances when none ought to exist. When we interview patients, when we meet patients, we are experts in a body of knowledge, but patients are experts in their lives, in their symptoms, and in their strengths. When we encounter patients, we need to reflect on the balance of power in that relationship. But lastly, and most especially, is to aspire to develop partnerships with people and groups who advocate for others. We as individuals can be tremendous change agents, but to truly affect change in the systems and structures that impact young people, that are at the root of disparities, we need to partner with others in this cause. Because there is a lot of work that still needs to be done in our classrooms, in our boardrooms, in our courtrooms, where the fight for equality is far from over. So for those of you that don't know, I moved here from Orlando, and I spent 12 years there, and I was, a big part of the LGBT community there. Pulse really hit me hard. That was in my neighborhood. We were good friends with the owners. I could have been there. And what's so amazing, though, is that out of this tragedy, that community became so cohesive. That community became so cohesive. I came here today with an agenda, a literal agenda. After the Pulse Orlando massacre, the community came together and they formed One United. There are over 40 organizations represented in that coalition. And they came together and identified the top 10 issues that affect the LGBTQ community in Orlando, from vulnerable populations to housing to racism. And they identified who among the 40 is going to be leaders in this. It shouldn't take a tragedy. And we're really working very hard to try to replicate the same and do the same for our folks here in Phoenix. And that's part of cultural humility. That's part of aspiring to develop partnerships with other people to try to elevate the lot of others. Now, let's talk a little bit about strength-based. A lot of the research on LGBT people and LGBT populations of color are framed in negatives. They're framed in victimization, rejection, hardship. While it's important to focus while it's important to catalog these and to reflect on these, because that's critical to developing interventions that might improve outcomes for the group, we also need to focus on the positives. We need to recognize the resilience that many LGBT people and LGBT people of color face. There's a small but growing body of literature around what young people describe as resilience factors. What are the things that promote positive outcomes in the face of adversity? And many of them are qualitative studies, which are beautiful because they capture the language of young people. They reflect a different dimension. In a qualitative study of lesbian, gay, bisexual people of color, one of the things that young people describe as resilience is to promote the development of positive self-concept. And I want to read some of this because I want to be able to capture some of the words that young people describe. Expounding on self-acceptance, youth described that exploring their sexuality allowed for the opportunity to be who they are, which resulted in greater feelings of happiness. To develop a positive sense of self that is not restricted by largely negative societal messages regarding how you should do, think, and feel. To not have to conceal your sexual orientation and gender identity behind something or someone. To believe in natural sexual diversity. To consider what is good about being LGBTQ. In our work with LGBT young people, we need to be able to develop the language and scripts to talk about their self-concept, about their life experiences and their life trajectories. And how do we promote positive self-concepts, right? So there was this one study that I found in the literature that sort of explored this construct because scripts are important. Pain, quality, radiation, severity, timing. Scripts are important because it's how we integrate, it's how we operationalize concepts into clinical practice. Meaning, what are some of the messages that you get about being? What does it mean? What does it mean to you? What are some of the supports that help you come to this positive sense of self? And I have a couple of stories for you. You know, I love being in clinic as much as it's really busy because it provides me with stories from the front. And, you know, I think back to this one young transgender African-American male, and I asked him questions about identity and meaning. He goes, I hate it. I hate it. Because my community, they kind of think of me as racist. Because I'm not racist, I just happen to be attracted to white people. My Latino transgender male, I was asking him the same questions. And he says, you know, it's not really about the trans thing because I pass really well. It's just that at work, he works at a hardware store. He says, it's just that at work, I get you peopled a lot. And they look at me funny. They think I'm stealing. I'm like, dude, I work here. Intersectionality, understanding intersectionality. Fostering supports. Youth also identify the ability to find safe and supportive LGBT spaces and people as a form of resilience, to connect and reconnect with family members where possible, to find an ally in school and at home, to seek support from others, to make a gift of your experiences and share them with others, especially younger people who are coming out. You know, family support can be transformative and life-changing for LGBT young people. Young people who are supported by their families do so much better on many measures of well-being. It's protective of substance abuse, it's protective of depression, it's protective of suicidality. Conversely, as clinicians, we truly have an opportunity to promote communication and connectedness between parents and caregivers. And for me, you know, I came to this work working with young adults experiencing homelessness. And I truly feel, rewind, that if we can create the kind of supportive spaces around young people when they first present, that is the face of prevention. That is what promoting positive outcomes for young people look like. So, you know, we in adolescent medicine, we're very good about the parentectomy. The first thing we do is we eject the parent, right? One of the things I've tried to do more and more is try to do shared visits with parents, especially as we talk about gender identities and gender experiences and sexual identity development, because I recognize that that young people oftentimes navigate these processes in private. And I tell my residents this, do not attempt at home. Professional driver on a closed track. Because in adolescent medicine, we're all eject, right? And so I introduce the concept to young people. This is your visit. I'm not going to assume that you guys don't communicate. I feel like there's reason to us visiting together because I recognize that young people oftentimes navigate their gender journeys in private. So as much as you will let me, and as comfortable as you are, I'd like to proceed with this visit together to the extent that it doesn't interfere with us getting good information. And I tell you that this family-centered model is something that I really want to write about. It's something that I feel is truly worth exploring because I see it works. I see it work. Now, I think also really offering ourselves as a resource to LGBT young people as far as coming out to their families to the extent that they're comfortable with is another way that we might be able to foster communication and connectedness. There's a number of resources out there that we as clinicians should know about, including this one from SAMHSA that really talks to providers around how we can broker, how we can foster supportive and affirmative environments. And it's really important to get to know community resources. Here in Phoenix, we have Arizona Trans Youth Parent Organization. There's PFLAG. Thinking about resources that might be sources of support for families. Schools. This here is a report from GLSEN, Gay, Lesbian, Straight Education Network, and it describes the experiences of LGBT people of color in our nation's schools, and the picture is not pretty. 8 out of 10 of these individuals have negative experiences of victimization and harassment in schools on account of dimensions not only because of who they are in terms of their gender and sexual identities, but also because of their racial and ethnic identities. What do we know about young people who experience hostilities, who experience victimization, for whom schools are not necessarily safe spaces? They're more likely to miss school, they're more likely to drop out. And we know how important academic achievement is to the future life course. Despite this knowledge, let's take a look at the state of safe schools laws. there is such a thing as enumerated laws. Enumerated laws are safe schools laws that are taken up by states to protect young people on the basis from discrimination and harassment. And what you see, the states in blue are the states in the union that have anti-bullying laws designed to protect students on the basis of sexual orientation and gender identity. There's a large swath of this country where there is not protections for young people in our schools against bullying and harassment. This slide shows you non-discrimination laws protecting students by states. And there's one state, Wisconsin, that has protections for students on the basis of sexual orientation but not gender identity. The ones in fuchsia have protections for young people on the basis of gender identity and sexual orientation. Again, large swaths of the country have no protections for our students in schools. This slide here shows what we call no promo homo laws. There are 7 states in the union. Unfortunately, Arizona, disgustingly, is one of them, that actually actively prevents educators and school individuals from portraying LGBTQ identities in any positive light. The good thing is, word is that there's actually bipartisan support to take down that no promo homo law in this next legislative session. This GLSEN report dropout, push-out, and the school-to-prison pipeline talks about how the negative experiences and experiences of victimization and harassment and discriminatory school policies cause LGBT young people and LGBT people of color in our schools to come into contact with school discipline. Expulsions, suspensions, and that it eventually pushes them out of school into nothing or into the criminal justice system. What can we do? 1, assist LGBT youth and families address school concerns when they identify them. Yesterday, I did an interview for Q Channel, specifically on schools, and I'm like, what can parents do? Ask your child how their day went, and be proactive. Be proactive. There are resources out there, such as HRC's Welcoming Schools and Gender Spectrum's Schools in Transition, where parents can actually work with schools to create affirming environments for their kids. Gender and sexual alliances, which are clubs, which are activities in schools that create inclusive spaces in schools, have also been shown to foster positive school climates and a greater sense of well-being for young people. Informal and formal mentoring relationships can also make a difference for young people. Here at Phoenix Children's Hospital, we've really convened also a trauma-informed practice work group. And they are really looking at how we create inclusive environments in our schools so that we might address these. And we, by the way, when you take a look at the original Adverse Childhood Experiences study, there was nothing in there about discrimination on the basis of one's identities. We now know that these function the same way as other adverse exposures. And what you will see is within this trauma-informed practice work group, there's a clear understanding that negative and hostile and discriminatory experiences function the same way as childhood adversity in terms of what it does to your neurobiology, in terms of what it does to your fight and flight responses. Mentoring relationships. We are very good about connecting our young people with mentoring relationships. About a month ago, I had the pleasure to serve with Big Brothers Big Sisters. And Big Brothers Big Sisters is now thinking about, hey, how do we become more inclusive as a system? And how do we include LGBT mentors for our littles? And so it's really great to see this kind of change that's happening. Employment. Under the patchwork of federal and state laws, 2/3 of Americans live in states where there are no protections in the workplace against for gender identity and sexual orientation. And that's something that really has to change. With our families, with our young people, we share resources such as those from Out and Equal about how you be a good advocate for yourself in the environment, in the workplace environment. Lastly, encouraging and promoting self-care. LGBT youth describe the need to take care of oneself, both at an emotional and physical level. To care for oneself emotionally is to acknowledge and be aware of the negative messages and heterosexist societal messages and to build strategies to resist such negativity. To seek help when needed, to seek opportunities to experience positive emotions of joy, empathy, compassion. To care for oneself physically is to take care of one's external appearance and to take care of one's sexual health. You know, historically, when we develop programs and services reaching LGBT people, we frame it from the standpoint of risk reduction because we view them as a community of risk when maybe we should be reframing how we deliver our services and message it in the context of asset building and resilience, not from the standpoint of risk. What can we do in clinic? One, think about how we connect young people with advocacy organizations and youth development opportunities that truly engage young people to be participants, to be advocates, to change the social conditions that affect them, to provide comprehensive medical and behavioral health services, to how we build that network of culturally competent and affirming providers and agencies. We do a lot of training and education for the provider workforce because we feel that's that's how we can help young people take care of themselves emotionally and physically. I had a young person come to me from 6 hours away, and this young person was initiating hormonal therapy and was a patient in the Indian health system. I am not going to disadvantage this young person because of where she lives. We worked with her primary care provider and we initiated and supported her primary care provider to assume that care because we cannot disadvantage young people on the basis of geography. When we take a look at access to gender-affirming mental health services, there is a big gap in this community. Young people ping-pong because they can't find a gender-affirming therapist. We were funded by the Arizona Community Foundation to train community mental health professionals, and we recently trained 29 clinicians across 14 Mercy Care contracted behavioral agencies so that we know clinicians who are not buried behind organizations. They are nameless. They were nameless and faceless. Now we know who to connect our young people with. And that's what it means to really build the kinds of systems that can help young people take care of themselves. Promote youth empowerment, engagement, and activism. LGBT youth describe activism as another form of resiliency. The need to understand the shared history and issues that have affected the LGBT community in order to guide their future aspirations. The need to educate and support other young bisexual men in order to promote their well-being. To educate others about the need to fight stereotypes, myth, and misconceptions. To gain strength through advocacy. To confront the social issues of my time. We should really get to know as well some of the advocacy organizations out there that truly engage youth as partners, as active participants in changing the conditions of their day. I talked about our Gender Proud Family Advisory Council. You know, DCS recently convened a work group to talk about their policies for LGBT young people. And it was amazing to see the number of young people around that room. That's how you engage young people in change. That's how you engage young people in change. But I want to talk a little bit about intersectional justice. You know, we are multidimensional beings whose life reflect the intersections of gender, race, immigration status, identities, right? And just as forms of subjugation and discrimination and oppression are interrelated, so are forms of justice. Rather than single axis approaches of Me Too, Black Lives Matter, Trans Lives Matter, we need to think about how we build horizontal approaches because we are multidimensional and create a platform where all lives matter. You know, we in medicine, we talk a lot about social determinants of health, right? It's become our catchphrase, right? More and more, we are increasingly called to think about the structural determinants of the social determinants of health. Yes, social determinants affect health outcomes. Income, place of residence, access to transportation, access to health care. But these social determinants are not static. Structures, social, political, economic, environmental, drive and maintain these inequalities in the first place. Let's not just look at social determinants. Let's look at structural determinants. Let's talk a little bit about structural violence. We need to recognize structural violence, which is the process by which social institutions cause harm to individuals and communities by preventing them access from the resources that they need to thrive. We need to think about structural vulnerabilities, how one becomes vulnerable to poor health outcomes because of one's location in the social world. as an institution that is charged with promoting the health and well-being of young people, we need to regard structural determinants of social determinants of health as inherently violent in as much as they leave our youth vulnerable. This is what the World Health Organization speaks of when they speak about health equity. And I know, it might sound like a lot of entitlement. It might sound like a lot of victimhood. But you know, there's a slide that's missing here, and it goes over the difference between equality and equity. Equality is fine if we all start out from the same place. Equality is fine if we all start out from the same place. Equity is about giving young people what they need to achieve equality. It's not the same for everyone. It's about how to give, to afford according to their need. Now is a really proud time to be a pediatrician. In 2018, the AAP revisited their agenda for children. And what you will see is that addressing bias and discrimination and also workforce concerns and physician health and wellness really figures prominently in there. And what you'll see here, because the one thing I didn't talk about is the experience of LGBT healthcare providers and the experience of providers of color. And there's a whole, we'll chat. And what you'll see in the AAP's agenda, even as we think about how we address bias and discrimination that impacts our children, youth, and families and that negatively affects their health, you cannot have a healthy populace without a healthy workforce. To think about workforce considerations and how we promote diversity and inclusion in our organizations that deliver care for our young people. And we are, what I would like to think is at the ground floor of this at Phoenix Children's Hospital. Again, I think it's a proud and opportune moment to be here. The AAP last year came out with their AAP diversity and inclusion statement that strongly opposes intolerance, bigotry, bias, and discrimination, especially in the context of today's xenophobic rhetoric. Last year, it was a proud accomplishment to be part of the group that wrote the Society for Adolescent Health and Medicine's position on racism as it impacts our patients, but also as it impacts healthcare providers, as it impacts students. You know, not that long ago, I think about a month ago, one of our residents who was visiting experienced an incident where a patient refused care. You know, no, I don't want care from you. And this is not unheard of. There's a tremendous body of literature that talks about, you know, I'm going to share something with you. I went to medical school in the Philippines. Did you hear Micah's bio? Did you hear Micah's bio? Did he say where I went to school? Why? Why? I have omitted that because you will make assumptions about me because of where I matriculated. You will make assumptions about me because of where I matriculated. And I probably do more for the young people of this country than many people that matriculated in this country. So thank you very much. Right? I'm missing a slide. I wanted to read a comment from a quote from Robert Kennedy, and it talks about ripples. It talks about waves. When you stand for another person, you create a tiny ripple, and that tiny ripple creates many other tiny ripples, and together these tiny little ripples can create a wave that can take down the mightiest walls of oppression and resistance. Thank you.